Okay, so this is Drew Walker. We're going to give the USMLE cardiovascular lecture, and we will allow you to scroll forward, backwards, and let's get started. So these are high-yield organ systems. I'm going to do a number of these to target the USMLE Step 1. Heart embryology, always important. There's a truncus arteriosus. These are ascending aorta and pulmonary trunks. Okay? So again, ascending, the aorta is out of the heart. Pulmonary trunk is where the pulmonary, say the input to the lungs. The bulbus cordis, these are the smooth parts. This is where the outflow tract occurs on both the left and the right ventricles. Remember, the left and right are based on the patient. So the left would be, actually, if you were looking at the patient, the left would be on the right side of you, the left of the as the patient. The endocardial cushion, this is the atrial septum, the barrier between both atriums. The membranous interventricular septum, again, that's the soft tissue between the ventricles. AV and semilunar valves. And remember, semilunar valves are called that because they look like half moons. Okay? Don't forget the semilunar valves. They're involved with the pulmonary and the aorta. The primitive atrium prior to full development. And remember, this is the heart embryology, so it's a little different than the adult. So here we call it primitive. Again, primitive prior to the real atrium. An atrium, remember, it's a similar to an atrium of a door or a house, which is it's a greeting area, gathering area before you actually get into the trabeculated part of the left and right atria, and the primitive ventricle, the trabeculated part of the left and right ventricles. The primitive pulmonary vein, this is the smooth part of the left atrium, smooth part, again, smooth tissue. And then the left horn of the sinus venosus is the coronary sinus. Again, sinus is typically a bifurcation. And the right horn of the sinus venosus, this is the smooth part of the right atrium. Okay? Again, the right sinus and venerum. The right common cardinal vein and the right anterior cardinal vein, these are the superior vena cava. And don't forget to see the superior vena cava. These are coming from the body on top of the heart, coming from the top, and it's on top of the superior vena cava. So again, it's coming from the top, typically associated with the upper limbs and upper body. Okay? Heart morphogenesis, again, the growing of the heart is morphogenesis. It's the first functional organ. You'll see that this is functioning first before any other organs in the embryo. Typically by week 4, it looks like a little bean of sort on a sonogram, and you'll see blood flowing very lightly. Cardiac looping, this is the folding. Think folding on this. Primary heart tube loops, and this is a again dextro looping, sometimes called. Okay. This establishes your left and right polarity. Again, beginning in week 4, because that's when the heart begins to pump. If you have a defect in your left dynein, this is again involved with your left-right asymmetric, can lead to dextrocardia. And so if you see on the USMLE, if you see anything about the cardiogenius syndrome, it's the primary ciliary dyskinesia. And this is typically a result of cardiac looping that is improper or faulty. Okay. Septation of the chambers. The atria, again, typically it should be on the top. Typically, these are a little bit posterior to the ventricles. The ventricles are typically on exam going to be much forward or anterior to the atria. You have a septum primum. It grows toward the endocardial cushions. They'll narrow in the foramen primum. 2, you'll see this septum primum here. So you'll see the septum primum here. Again, it's bifurcating the right-left atrium. That's the term you should be thinking of when you see a septum. The foramen primum. Foramen, again, is opening because it's typically very close to the original or initial, they'll call it, and it's very large, it's primum. Step 2 here, the foramen secundum forms in the septum primum. So again, here you have another opening, a second opening of sort, and step 3, again, you have the septum secundum develops as a foramen secundum, maintains a right to left shunt. So here's your right going to the left. Okay. And then step 5, or step 4, your septum secundum, here it is left to right, or right to left, I'm sorry, looking at it from the patient side. The residual foramen is then the foramen ovale. Okay. Foramen ovale, again, it's right here. It's a very small opening. 5, remaining portion of the septum primum forms valve of the foramen ovale. So that's definitely, it becomes closed. Hopefully it closes properly. Septum secundum and septum primum fuse to form the atrial septum. Okay, so this should grow across. Okay, and if it does grow across, then that's a proper normal fusion. The foramen ovale usually closes soon after birth because of the increase in left atrial pressure. So you see that comment. Also, you'll see very common on the USMLE is this patent foramen ovale, or ovale, however you want to say it. Both are acceptable. And when you say patent, whenever you see that word, know that it's unusual. It's caused by the failure of the septum primum and the septum secundum, again, the first and second septums, to fuse after birth. Now, if they don't fuse, you get a hole. And that hole is called is what they're going to call as patent. Most are left and untreated because they kind of heal themselves over time. But they can lead to paradoxical emboli. This is where you have a venous thromboly that enters the systematic arterial circulation, similar to those resulting from articular septum defect, ASD. So again, basically a hole again. Just know that this patent foramen ovale right here, you don't see it, but basically it's this foramen. Here it's supposed to close in step 5, but if it stays open, again, it doesn't fuse after birth. That would be a patent foramen ovale. Just makes the heart less efficient in a sense. People still live. Then you have this heart morphogenesis, again, ventricle portion, again, the lower part, the distal part of the heart. Muscular interventricular septum forms. Okay. Muscles, again, these are going to be thicker, okay, than the membranous, membrous, however you want to say it. Aortical pulmonary septum, again, that's the bifurcation of the aorta and the pulmonary valves or tubes. Okay. Again, they should grow and fuse with muscular ventricular septum to form some membranous interventricular septum. Again, membranous is not going to be as strong or as muscular, typically toward the center of the heart. Again, closing interventricular foramen. Again, you don't want a hole, so you have to close the foramen. That's your step 2 here. Notice in step 1 you have all of this open here. Okay. And again, interventricular foramen. Inter, not intra. It's inter with a T-E-R. Make sure you get that right on the test. The atriovascular canals. So this muscular, you'll notice right here, it's much thicker than the top portion, which is the membranous interventricular septum. So you'll need to differentiate between those two. The growth of the endocardial cushions separates the atria from the ventricles. Okay. Again, that's where the mitral and the tricuspid will be, to both the atrial septation and the membranous portion of the interventricular septum. Again, the middle part. So you might also have a VSD, the ventricular septum septal defect. Again, it usually occurs in membranous septum because that's the thinner, more thinner tissue, so it may not close properly. And here you'll see in step 3, you might have a gap there. And that's your VSD. Outflow tract formation. This is where your neural crest and the endocardial cell migrations occur. You have a truncal and bulbar ridges, and then these that spiral. Okay, so they start turning and they fuse these fusing and from this, sometimes they call it looping, but typically on this one it's going to be spiral. If it's looping, it can, uh, it's more of a fold. Spiral, again, it's more of a twist. But they fuse and they form the aorta and the pulmonary septum bifurcation. That's called the aortic pulmonary septum. It'll also create the ascending aorta, again, the aorta coming out of the heart upwards, and then the pulmonary trunk going into the lungs. Contratruncal abnormalities can be caused with failure of the neural crest. Again, if they don't create this aorta and pulmonary septum called the aortocortopulmonary septum, you might have a transposition of great vessels, tetralogy of Fallot, and the persistent truncus arteriosus. Again, the cause of it. So on the exam, they might say there might be a persistent truncus arteriosus. What's the common cause? You might see contratruncal abnormalities associated with the failure of your neural crest cells to migrate. That's what you're looking for in the test. Valve development. Okay, again, now you have the valves, not just the trunks or the tubing. Tubing, otherwise known as the aorta or the pulmonary trunk. You might have aortic pulmonary valves will be derived from the endocardial cushions. Now, make sure you know endocardial, not meso or exo. Why? It's endo because it's internal to the heart, cushions of outflow tract. You might have a mitral tricuspid. Remember, the mitral is also called the bicuspid. These are derived from fused endocardial cushions of the arterioventricular canal. Okay? So the bifurcation between the atria and the ventricle. Valvular anomalies may be stenotic, regurgitant. In other words, they may be narrowing, stenotic, or they may be regurgitative, where the flow actually goes back or backwards. Atretic, may not get through to the other side of the tricuspid, or displaced, such as the Epstein anomaly. Now, in case you're wondering or can't remember, let's go through these. Again, the Epstein's anomaly, it's very rare, but it does show up on the USMLE. It's when the tricuspid valve, the valve between the upper right and the lower right chamber of the heart, the atrium and ventricle, it doesn't work very well. No, it doesn't open and shut, so blood will leak back through the valve and back into the right atrium. An atrial septic defect is the hole between the two upper chambers of the heart, again, between the two atriums. So, again, typically about half the people with an Epstein's anomaly also have an atrial septal defect. Okay? And here you'll see the enlarged right atrium, kind of fused almost together, but this Epstein's anomaly, the valve here just doesn't shut very well. And don't forget the tricuspid atresia, very similar. This is a heart disease that is present at birth. It's congenital typically. It's where the tricuspid heart valve is missing. Well, that's a problem. Or isn't developed properly. So again, it's not the adulthood, it's the children. So the defect blocks the blood flow from the right atrium into the right ventricle. Okay? So that's it for this video.